I'll kick us off. Good afternoon, everybody here in person and then virtually. Let me start. Oh, we are recording, okay, and then I just got to share screen and we can get started. All right, looks like we are good to go. Okay, I want to start by thanking the ACMI folks and all of you today for the invitation to speak. Something we're really passionate about is the topic of rural mental health. I'm going to start today by presenting on kind of the Department of Population Science and Policy, where us three are from, but also SIU School of Medicine, as I understand. Not everybody here may be familiar with us. So I'll give you a background of who we are and what we do, and then I'll hand it over to Vistrit, who will go more in depth on rural mental health, specifically a policy brief we've released over the last year, and then also more, some effective legislation and statistics just that kind of lay bare how dire the situation is in many of the rural counties in Illinois when it comes to mental health. And then finally, once Vistrit and I are done talking about the policy kind of aspect of rural mental health, we're going to turn it over to Jessica after a brief, punctual, as Donna said, 10-minute break to talk about an innovation that PSP has actually implemented in the field in Hillsborough, Illinois. All right, so I'm going to take us back 52 years to 1970, and that is when Dr. Richard Moy was named the founding dean of the Southern Illinois University School of Medicine. And he was urged by the Illinois Board of Higher Education, told we need a school of medicine in Southern Illinois. So they named him the dean. At the time, he was the country's youngest dean of any medical school in the country. And the mission that he came up with, as you can see at the top of the pillar structure, is assisting the people of Central and Southern Illinois in meeting their health care needs through 4 specific pillars: through education, patient care, research, and service to the community. And as much of the work we've done with them through our research arm at our department, and then also Vistrit and I working with them in policy, is those 4 pillars ring true today, 50 plus years later. That is what our med students are focused on. And each year we have 280 medical students and over 350 resident physicians and fellows trained in 25 medical specialty areas. Furthermore, school has furthered its mission through the establishment of population health focuses, specific educational programs for physician assistants, medical scientists, and underrepresented groups in medicine through our Med Prep program. So that Central and Southern Illinois service region that Dean Moy came up with is on your screen. For those of you who aren't familiar kind of with much of Central and Southern Illinois, to break it down in the easiest possible way, that is, our service region is a lot of land and not a lot of people. They are spread out all across. So that makes it challenging to be able to affect the most people in the shortest amount of time for us. But specifically our service region is 66 counties, which is predominantly rural or non-metropolitan. And we generally, when we're talking about, break it up into 4 categories. One being our main hub, which is Sangamon County, where we're based out of in Springfield. And then also Macon County, where we have sites for family and community medicine. Then we have our western, eastern, and southern regions. Western, we have a site in Adams County, which is Quincy. And then eastern and southern Illinois, obviously the main hub there being Carbondale, where the Southern Illinois University Carbondale campus is at. Our service region, we have to serve over 2 million people, and we cover, like I said, a lot of land, 32,000 square miles. Each of the regions I previously mentioned are roughly 20 to 22 counties, and just under 500,000 people in each region, and each one is somewhere between 9 and 11,000 square miles. Okay, so now that we've laid out kind of the School of Medicine, talked about the service region, talked about the founding of the School of Medicine, I want to talk about us as a department. So Population Science and Policy serves SIU's social mission to improve the health and wellness of residents in our service region. But we take a slightly more specific approach to coming through on that mission, and that is to take a new approach and through our 3 divisions, epidemiology and biostatistics, human and community development, and health system science, to combine data analysis, community engagement, and then policy formulation to address the social determinants of health. And as you have on the timeline there in the bottom, 1970, we were founded, the School of Medicine, but then we launched originally as an office in 2016 I was one of the original dozen or so people, and in 2 short years, we became a full-blown academic department at the School of Medicine, the first one in over 30 years. And now we've grown to just under 30 people. Additionally, we are one of the nation's first population health-focused academic medical departments and remain one of only a handful focused primarily on underserved and rural communities. So, what is population science? From a general level, it's understanding why certain populations are healthier than others. So, a lot of the time, we are looking at community health reports, where we can look at either from the down all the way to the census tract level, block group level, comparing states, counties, towns, whatever it may be, to get an idea, what is one county doing or one area doing better than the other? What are the cultural factors that can contribute to poor or better health? So that's what we set out to understand. And in that, we, instead of like a lot of population health departments across the country, we really feel that the policy component to that is important. Because we don't want to just be somebody who comes in with a grant project that lasts 3 to 5 years, then we pack up and leave at the end of that and kind of leave people stranded. So instead, we want to make sure we have that policy component to make whatever project that HCD and Jessica and her team go into a community with, we want to make sure we can give them the tools they need to then take that long term and embed it fully in their community. So our mission, as you'll notice, is very similar to the school's mission. We seek to understand the challenges of the people in Central and Southern Illinois. But where we vary is, instead of providing clinical care like all the other departments, we want to provide innovative, sustainable solutions to improve the health in these communities. Now, we do that primarily through our 3 divisions, epidemiology and biostatistics, which is our traditional academic research arm, and they work to gather and analyze data and then publish the results. So what a lot of people would generally think of when you're talking about a research department. But then we also have the Human and Community Development Division, which is represented today by Jessica, and they collaborate with communities to identify, design, and implement effective solutions to improve health through mixed methods research. So they'll go in, do needs assessments, surveys, interviews, focus groups, etc., with the idea that we never want to go into a community with a predetermined plan or project. We don't want to try and fit a square peg into a round hole. So we go in, we do all the work prior to ever implementing the project, and make sure we are addressing their needs and not just basically fulfilling our research obligation. And then finally, what Vistrit and I do in health system science is use evidence-based research to inform and improve local, state, and national policies that affect the health of rural and underserved populations. And the work, as you can see on this slide, the county health rankings from RWJF, our service region in those central and southern Illinois parts, it's bleak, especially in southern Illinois. They rank in the bottom quartile in outcomes and factors. And then also, when we're talking about the percentage of population in poverty, you'll notice the darker shades of purple tend to be located in our service region. So those lend a lot more difficulties in our mission to improve the health of these people. These communities are, while they may struggle, and you look at all these charts on a page and, oh, it looks terrible. What we've noticed, though, when we go into these communities and talk to people in these focus groups is they're powered by innovative, resilient residents. Like, they all have their go-to people that everybody in the town knows. If there's a problem, if there's a champion that they need, they all know who it is. But the problem comes in with they face unique challenges many times, and when it comes to the solutions, they have fewer resources than a lot of the urban areas. So when we think, right, like, we hear all the time is, that may work in Chicago, that's not going to work here. So that's why we have to do a lot of work on the front end in our discussions with them to make sure we are not outsiders, and we really need to develop a relationship with these communities. All right, now the areas of interest. So again, broken down by divisions, our Epi and Bio division, their main project, which is NIH grant-funded work, is the ETHIC project, or as their acronym stands for, Ending the Transmission of HIV, HCV, and STDs by PWIDs, which are people who inject drugs. So that project, in addition to looking at people who inject drugs in the Delta region, Southern Illinois, it has some outlier parts as well that are harm reduction services and making sure, or at least understanding where there are places for people who inject drugs to receive clean needles. And with that comes all of the issues as far as cultural attitudes and stigma regarding people who inject drugs and drug users. And we've run into a lot of times in Southern Illinois in our service region is they're drug users. Narcan, perfect example. They don't think Narcan should be available at pharmacies. They don't think cops should be required to carry it and to use it on somebody who is overdosed. That's one of the refrains we hear a lot about Narcan. Then when we talk about syringe exchange programs, is, well, you're just giving them the tools to continue abusing drugs. We always, this project kind of came out of in Indiana. They had the famous county that kind of ended any type of help for people who inject drugs, and they had a massive transmission of STIs and STDs as a result of that. So that project is kind of born out of that, hoping to make sure that doesn't happen in Illinois. And then we have the Rural Harmony Project by the Epi and Bio team. And that is the initial goal of the program being to better understand the health and well-being of rural people, but with a keen focus on sexual and gender minorities in rural Illinois. And as we've gone on the project to gather data, gather information, a developing goal has been to take that information that we've learned and collected to inform best practices and potential interventions to improve the quality of life and reduce isolation. Another result of that project is we actually, as a department, developed a Facebook page that can serve as an online community for those people and has had great success at overcoming a lot of the social isolation and isolation that comes a part of being a sexual or gender minority in many of the counties within this region. And next, Human and Community Development, the Healthy Hillsborough Project, which Jessica will talk about, their award-winning NRHA project. So I'll leave that for her. And then the other project currently in the works is by faculty member Ann Shear. It's Child-Friendly Cities, which is taking place in Alton, Illinois. They're still in the pre-implementation phase. And that's using the UNICEF framework that says essentially a city, town, or community needs to make sure the voices, needs, priorities, and rights of children are an integral part of any public policies, programs, or decisions. And then finally, health system science, which again, that's Vistrit and I. Our two big kind of landmark projects are, one, the Rural Health Summit, which focused on 9 topic areas, and you'll see them in the infographic there. Children's growth and development, nutrition and fitness, an aging population, opioids, the opioid epidemic, public health systems, rural health workforce, mental health, economic development, and healthy housing. And we came across these 9 topics after many discussions with stakeholders in rural areas and people who are dealing in these communities every day. And these are the 9 they came up with. And essentially what we did with the Rural Health Summit was we wanted to create a blueprint that could serve as a path to improving the health of rural Illinoisans. And that had, with those 9 topics, a corresponding policy brief and webinar for each one that we did over the last few years. And then finally, the Veterans Summit, which was it's a 2-parter. We did in 2018, was in person in Mount Vernon, Illinois, and that was a 2-day event. First day being your more typical conference like we're doing here, where you have speakers, people just kind of educating the audience on the topic. And we made it kind of interactive, but then the second day was the most important part, because we didn't want to be the people who bring in vets to talk about their struggles. So we made sure on that second day we had a resource fair. And in that resource fair, we wanted to be able to connect veterans and give them warm referrals, right, for any physical, mental ailments they may have, connect them with VSOs and other organizations that serve veterans that they may just not know about. All right, I'm going to talk a little bit more about the Rural Health Summit, and then I'll be able to turn it over to Vistrit. So the inaugural Rural Health Summit was in 2018. It was an in-person event and took place in Springfield. And again, it was those 9 topics from the previous slide. And we wanted to make sure we covered all our bases as far as stakeholders. So we had policymakers, people from the Illinois General Assembly, people, federal legislators, people in healthcare, public health, business, philanthropy, community service organizations, to all have their voices heard. So we got the most thorough kind of analysis and voices involved in that project. And then as you can see on the slide, the front, that's kind of the front page of the brief that was a product of that first event. And then we fast forward, and we had plans to have a second Rural Health Summit in person. Pandemic happens, March 2020, those plans are scuttled, so we were trying to think, how can we keep this going? And we decided to have discussion forums instead of another in-person event. So we utilized a lot of the same people that we had at that first event, but then also branched out, kind of grew the audience. And we ended up having 80 leaders from 55 different organizations across the state and share the challenges that they personally and then their organizations faced from the pandemic as a result. And that took 11 discussion forums, all moderated, and essentially the thing they came up with were the 5 Ds, is what every rural Illinoisan has to deal with. And those are disadvantage, which is you're starting at a disadvantage a lot of the time. As you saw, higher poverty, higher uninsured rate. A lot of those indicators that we see and variables tend to be worse off in rural counties. Next, deserts. Anybody that's done any work in rural communities, data is hard to come by and makes our job even more difficult. That's why we have to rely a lot on our qualitative methods. And those deserts range from just data to food to healthcare, social services. The transportation issues play a big part in those deserts. And then the disconnection, not only broadband but organizations, connecting organizations and having systems of care that truly works is a lot more difficult when your PCP may be in your county that you live in, but then you got to drive an hour and a half to go see the specialist they refer you to. Next, disparities. Surprisingly, a lot of the disparities that we see in rural areas are mimicked in our urban areas, our metro counties. Difference being less resources and honestly less people working on those issues than you see in a Chicago, a Springfield, a Bloomington, Peoria. And finally, development. They experience a lot less development, right? Economic development, there aren't people coming in building new hospitals and clinics a lot of the time. Instead, we see them shutting down or having to cut, OB-GYN departments and they're more likely to be cutting development than increasing development. And finally, I want to talk about our webinar event series that we just had. And that was, as you can see here in our little box, our highlights is we had 1,200 registered participants for the 9 webinars we hosted. We had 20 rural experts to talk in those roundtable discussions, and then we released 10 reports or policy briefs on those. For more information, you can actually scan that QR code. I guess that's easier for the virtual people, and that'll link you to our website. You can watch the webinars if you want, or take a look at the policy briefs. And then finally, the 2022 Innovating Rural Health Event Series. We're going to cap it off in October, the end of October, at the Memorial Learning Center, for those who are familiar in Springfield, with an in-person event, God willing, and that's going to focus on rural health policy, specifically with federal, state, and local implications. And with that, I'm going to turn it over to Vistrit.
For some reason, so I'm not sure if there's a way, since the, do you know if there's a way to do the slides?
It should be. Yeah, I shared screen. It should be going.
They're saying it's stuck on the first slide.
That's weird. I mean, it does. You can stop the share and start it again.
So I wonder, maybe it's the screen.
Mm-hmm.
Maybe you share that one. Maybe it was on. I don't know.
Possibly. Let's see. Could we check if it's moving?
Let's see if there's a way to ask in the chat box here. Is there a way to get, I just need to hit escape. Screen sharing is stuff, oh, so you can't do that. For the folks online, if you could let us know, just speak up if you can if you can see the slideshow. That's, we're gonna share the screen again and see if that works.
Got it. Thanks, Jody.
Is it this one here?
Yeah.
Okay. Sorry about that.
Yeah, the last one just stayed on the first slide the whole time.
No. Can you see?
So it's on slide 11.
Folks online, is this working for you now?
We can see it, but last time we could see it and it just stayed on the first slide. Maybe try and forward it.
Mm-hmm. Okay.
Did you see that change, or is it still stuck?
It's still stuck.
No. It might have something to do with integrating the meeting owl. I'm not sure.
Okay.
We've not had that issue, so I apologize. I mean, I'm not really sure how else to.
Yeah, no worries. If somebody if you have it handy and you could email it to me.
Is it like sharing wrong? I don't know.
It looks like it's sharing the right screen, so I'm not sure.
Do you think it would be okay if we could email the presentation?
Yeah, we'll email you the presentation if that's okay.
That'd be great.
Okay, great.
Thanks for trying. Sorry to interrupt.
Thank you. Well, Zoom had to mess up a bit. It's not the pandemic unless the Zoom stops working. So, alright. Well, is everybody able to hear me okay? Do I need to speak louder? I hope this helps. Okay. I have never used a lapel mic, so, well, first time. So, thank you, TJ. Thank you for that introduction of our department and the work that we do. I'm Vistrit Choudhary. I'm a health policy coordinator with the Department of Population Science and Policy at the School of Medicine at Southern Illinois University. Through the course of the next half an hour or so, I'm going to talk about the landscape of mental health in the United States and focus on some of the challenges that rural areas face when it comes to mental health delivery. We are also going to explore the effects of pandemic on mental health, look at statewide and federal policies which have been instituted to address some of these challenges, and also present some of the recommendations that we as the Department of Population Science and Policy feel fit to improve the mental health of rural Illinoisans. The COVID-19 pandemic, as we all understand, is one of the biggest public health crises in the past 100 years. The pandemic, hence, has been instrumental in revealing a lot of deep-seated fault lines within our healthcare infrastructures, not just in our rural areas but also urban areas. The pandemic is also very personal to us. We've heard stories of our friends and families being affected by the pandemic. We've had anxiety about our own health and the health of our loved ones, and this has obviously added to a lot of the mental stress that we've all faced collectively in the past 2 years. What the pandemic has also done is that it has brought forth some of the systemic inequities and problems with our healthcare delivery system and made us aware to the fact that our healthcare delivery system is not as robust as we would once believe. Anecdotally speaking, the major disruptions in our day-to-day life because of the pandemic has helped trigger or manifest some of the mental health challenges that we've been facing. If we look at the numbers on a population level, the US Census Bureau estimates that the average share of adults reporting anxiety or depressive disorder symptoms grew 30% between the first half of 2019 and January 2021. Over the past couple of years, because of the pandemic, awareness around mental health has increased out of just the public health domain but into the public sphere, and there is a momentum for action at this point. Hence, we are thankful to organizations such as ACMI for helping us drive the conversation and collaboration around mental health, which is one of the most pressing issues of our time. So, as practitioners and researchers and members who do take a keen interest in this field, we know the effect of mental health on physical health and vice versa. But it is also important for us to explore the tangibility of mental illnesses on physical health. According to the CDC, as you can see on the slide, 1 in 5 Americans will experience a mental illness in any given year. Additionally, 1 in 25 Americans live with serious mental illnesses such as schizophrenia, bipolar disorder, or major depression. The CDC also estimates that more than half of Americans will be diagnosed with a mental illness or a disorder at some point in their lives. If we explore the prevalence of these mental illnesses according to age, we find that adults between the age of 18 and 25 have the highest prevalence of mental illnesses, with 30.6% of people in this age group exhibiting symptoms. Paradoxically, this is the group that is the least likely to receive care for their illness, as only 41.2% of people in this age group receive any treatment. While the prevalence of mental illnesses is lower in populations 26 and above, it is the population that receives a lion's share of our mental health treatments, which is more than what we actually have for young adults. Now that we have established the propensity and how big the public health challenge mental health poses, it's prudent to explore how mental health has ripple effects on a person's life and how it's inextricably linked to chronic conditions. According to the American Heart Association, people who go through serious mental illnesses are at double the risk of developing cardiovascular diseases as compared to the general population. Additionally, the risk is further exacerbated when we consider that patients with poor mental health have an increased risk for cardiac reinfarction, as well as poor glycemic control. Consequently, all these issues add up with people with SMIs have a lifespan that is 13 to 30 years shorter than those in the general population. So as we can imagine, like, this is a very big problem that we face not just as individuals but also as social systems. Apart from the human tragedy of having a life cut short because of a condition that could be addressed, the numbers add up to in terms of economic burdens to societies. According to the USC Schaefer Institute for Health Policy, SMIs such as schizophrenia, bipolar disorder, and major depressive disorder carry an economic cost of more than $1.4 billion per disease, and that's just in Illinois. However, contrary to what a lot of people might believe, these costs aren't direct medical costs. Direct medical costs only constitute 12 to 47% of the economic burden of these diseases, depending on which disease we're talking about. But 50 to 85% of the economic burden of mental health comes from lost productivity. Hence, mental health does not just impact the individual. It impacts people around them, it impacts the community. Consequently, a coordinated approach to addressing mental health challenges is not only helpful to the individual to get over some of the crises that they face, but also has the potential to generate positive consequences for the community. Now, let's concentrate on mental health in rural America. It is important to recognize that mental health issues are as much a rural issue as it is an urban issue. When we compare healthcare delivery challenges for underserved population in urban and rural communities, we see that the rurality of the context in which this care is delivered creates an additional challenge to carers, to policymakers, to providers, and community members who work on this issue. In this section of my presentation, I'm going to talk about how mental health challenges look like in rural America. To just set the context of the population that we're talking about, I'm going to give you some quick numbers and quick facts about rural America as such. We know that rural populations are older than urban populations. According to the US Census Bureau, 17.5% of the country's rural population was older than 65, as compared to 13.8% in urban areas. Rural households are also reported to be poorer, with a 2018 study from the Federal Office of Rural Health Policy stating that rural populations had a median household income that was $16,000 less than those in urban households. Rural areas also report higher poverty rates consequently, and rural residents are also more likely to have mental illnesses as compared to urban counterparts. According to the National Survey on Drug Use and Health, 18.7% of non-metro residents reported having a symptom of mental illness to the previous year, compared to 17.6% in large metro areas. This difference is even bigger when we look at the population which is aged above 26. 23.3% of non-metro residents between the ages of 26 and 49 reported mental health symptoms, as compared to 19.6% in large metro counties. According to the US Census Bureau, residents in rural areas also lack the insurance, which could be a key to providing the coverage and the affordability to seek care for these diseases, and any disease for that matter. About 12.3% of people in completely rural counties lacked health insurance, compared to 11.3% for mostly rural counties and 10.1% for mostly urban counties. Moving on, we would like to spend some time to explore what are the key challenges which serve as barriers for delivering mental health care to rural areas. So the two things that came up through the conversations and the research that we've seen through literature is that accessibility and availability combined with stigma around mental health are the two major roadblocks which restrict access to care to a lot of people who might need it. Speaking of accessibility and availability, Those of us who've lived in rural areas or smaller towns know how difficult it might be to get an appointment for a doctor or for a specialist. So the lack of a rural workforce combined with challenges of transportation and physical health infrastructure such as hospitals and clinic combine to form a perfect storm of reasons why people can't either access care when they need it, that is provided that the care itself is available. Rural communities are also characterized by the idea that everyone knows everyone else. In a smaller town, you are more likely to know your neighbors than you are in urban areas. I speak that from experience because I spent 2 years in Chicago during my master's program and I didn't know my neighbors compared to what I see in Springfield, that it's a more collegial environment. However, the collegiality and a strong community ethos in rural areas also reduces the expectation of privacy in these areas. And this is a very important factor when we look at mental health access from a stigma perspective. We all know that with any healthcare, especially mental health care, patient privacy is extremely important, and like privacy about your condition is also something that is sacrosanct. However, when you are in a town where there is only one provider or one pharmacy, you go in and get a prescription of sertraline, suddenly there is a propensity for everyone in the town to know that you're suffering or you're hurting. This only causes an increment in the impact of stigma in these areas. So we will get into all of these challenges in a bit more detail as we go forward with our slides. So I'd like you to take a minute to look at this map. Look at it closely. You see that these are two maps which talk about the presence or absence thereof of mental health workplace across the country. As you can see, counties with none of the counties in a shortage area or counties which have a partial shortage are mostly located in the west or east coast urban areas. A vast majority of the United States geographically is in a place where they do not have enough mental health professionals to provide them the care that they need for a burgeoning mental health crisis as that we have on our hands. Furthermore, if we look at child and adolescent psychiatrists, the numbers are equally as dire. So this is what we see as a national trend. Let's see if Illinois fares a bit better. Again, you see that the urbanness versus the rurality of the context in which health professionals operate creates a huge disparity in terms of the presence or the availability of mental health professionals. In Illinois, as you can see, except for some areas adjacent to the Chicagoland community or the ones which are closer to East St. Louis, most of our state is in the throes of a very acute mental health professional shortage. This gets even worse when it comes to analysis of child and adolescent psychiatrists in these areas. You might be shocked to know that Illinois only has 344 practicing child and adolescent psychiatrists, and most of these are concentrated in 21 counties. If we were to rank the counties with the presence of CAPs, we see that Cook, DuPage, Lake, Sangamon, and Will County have the highest number of CAPs in the state. However, 80 counties or 80% of the counties in Illinois have no children and adolescent psychiatrists. Furthermore, one of the challenges that we face with rural workforce is that we have an aging physician population and an aging provider population. This holds true even in case of children and adolescent psychiatrists, as the median age for these providers is 51 years. Now, that might be a specific population that we might be dealing with, but let's also look at the map that we have on the right, where we are looking at mental health and substance use facilities who accept Medicaid. This map is from SAMHSA, And we can see that there is a huge concentration of providers who accept Medicaid at Chicago and the more Metro East area. But for the rest of the state, while you have clinics, the fact is large swaths of our state are in between two providers, and people who live in these rural communities may not have the transportation, especially at a lower income level, to access these clinics. So when I talked about the physical infrastructure of our healthcare being concentrated and being disparate across rural areas, this is what I kind of meant. So that's the challenge in terms of accessibility and availability. We discussed about the concept of stigma and embarrassment about seeking care for mental health, and especially in rural areas. But for the most part, we understand this as an anecdotal trend. But this time we have some numbers to prove that that's not just a trend that we anecdotally know, but there is some numerical rigor to it. These two graphs, as you can see, came from a survey that the American Farm Bureau Federation did in December 2021, which looked at 2,000 adults nationwide in rural areas and asked them about questions regarding mental health. As you can see on the first graph to the left, stigma associated with seeking help or treatment, 51% of adults who were surveyed in this questionnaire agreed to the fact that they would have some stigma associated with accepting care. Furthermore, if we dig deeper, we see that 52% of survey participants respond in the affirmative to saying that embarrassment is one of the reasons why they might be hesitant to access care. So when we talk about rural populations, even if we take the question of accessibility and availability out, the problem of stigma is another layer which adds to the complexity of delivering the sort of care that we need to get to these people. Moving on, let's now discuss the impact of the pandemic on mental health. We've all seen this happening on our lives, but let's look at it from a more academic / numerical sort of an understanding. We've gone in depth with our understanding of the effects or challenges of mental health in rural communities. We now shift our attention to the pandemic. The uncertainty posed by the pandemic, especially the anxiety about health, financial situation, or lack of community, has contributed to a precipitation of a large mental health crisis across the country. When we look at the Kaiser Family Foundation data on adults reporting symptoms of anxiety or depression, we see an increase in symptoms for anxiety and depression around November 2020. Illinois also seems to follow the similar trend, except Illinois actually started higher in April 2020. The numbers have fallen and stabilized as of now, but the fact is we are still at a substantial level of people reporting symptoms of these two disorders. We are now going to look at severity scores. What do these graphs mean? These graphs basically are results from a survey which assesses the severity of generalized anxiety disorder and depression in populations across the country. A change, as you can see over here, means an indicated change in frequency of symptoms. So as you can see, Illinois, over the whole study period, which is from August 2020 to September 2020, has been at a level higher than the rest of the Midwest. We are doing far worse in terms of anxiety compared to our peers in the states around us. With regard to depression, a similar trend can be seen, that we started off worse off than the rest of the Midwest. We peaked around the December-January 2021 sort of a time period, and we fell down again, but we are still slightly higher compared to the rest of our Midwest peers. One interesting thing to note about this study is that the study tracks the results before the advent of the Delta variant and its widespread and the spread that it had in our communities. Authors of this article mention that the conclusion of the study before the Delta surge may not have captured a slowing or reversal in the decreasing trends of anxiety and depression. So there is a good chance that if this study continued beyond the time frame that it did, we would see these trends reversing. Overall, authors of the report suggested that average anxiety scores increased 13% between August and December 2020, then decreased 26.8% between December 2020 and June 2021. Similar trends were noted in case of depression scores as well. However, the authors of this study also said that there was a strong positive correlation of COVID cases with both anxiety and depression. So we know that an increasing caseload is causing an increase in mental health symptoms that we see across our populations. This is a nationwide study. We were not able to get the numbers for a rural population, but we were able to dial it down to a bit of our Midwest peers. Now, we have heard about the challenges that mental health creates in our communities, the impact of these challenges, how these challenges have evolved as the COVID pandemic has gone about. But what about the response? So in this section, what I'm going to do is I'm going to take you through some of the policy interventions that we've seen happening in the state and the federal level in the past 2 years. Just to give you a quick peek of what those trends look like, they generally revolve around creating capacity and using novel means by which we can leverage our existing health infrastructure to expand care. So when I talk about that, I talk about telehealth. One of the key instruments that policymakers have used in expanding access is to use connected care technologies such as telehealth. In the next few slides, we are going to explore some of these interventions in greater detail. We first start with our own state of Illinois. Illinois has been innovative in its approach to addressing the mental health crises using legislative means to expand access to previously underserved populations. Illinois has worked on building a workforce capacity, ensuring a parity for providers serving lower income populations, and also ensuring that telehealth is more accessible to the state's residents. We will go through some of the key policies we've identified to this effect through the lens of two major challenges that we have talked about earlier: accessibility and availability, and stigma. So the first law that I'd like to draw your attention to is HB 158, or the Illinois Healthcare and Human Services Reforms Act, which was enacted in April 2021. And it approaches the challenge of rural mental health delivery by addressing workforce reimbursement and reducing stigma. The Act requires the creation of a community health workers training and certification program within the state. This provision is of key importance for healthcare superutilizers in rural areas. Community health workers can serve as an important bridge in our healthcare system to not only coordinate care but also to identify and address some of the challenges pertaining to the social determinants of health that we see in these populations. By healthcare superutilizer or high utilizers, what I mean is those people who tend to visit the ER more often than the general populations, not because their disease condition merits it as much as the fact that they do not have the social determinants of health in place to seek the sort of support that they need. Previous research has shown that investment into community health workers and care coordination services are helpful in deriving cost savings for our healthcare system. Now, this is of prime importance for rural hospitals and rural communities because many of them continue to face financial challenges which threaten their existence, and any cost saving is a cost saving that keeps the door open for a longer period of time. Additionally, the law has also increased payment rates for psychiatric treatment hospitals who serve low income population The law directs the state DHS to fund and collaborate with the Illinois Behavioral Health Workforce Center by providing a $6 million initial investment for a higher education institution to use a hub and spoke model to partner with other institutions to identify interventions for strengthening the Illinois behavioral healthcare workforce. On the stigma side of things, the law also uses a training based approach to address some of the implicit biases that we see on the provider side. This is extremely important because if populations are worried about being admonished or being judged by our providers, they will never seek care. And that only fuels further the problem of stigma that we see in our communities with regard to mental health. Additionally, the law also tries to address stigma and awareness on emotional health, trauma, and adverse childhood experiences from early childhood by requiring daycare providers to be trained to identify such issues. So, we are really starting early here to build that awareness about the challenges of stigma with mental health. The law also stipulates a safe harbor from criminal prosecution for patients or others who seek emergency care for overdose. What the last section of the law does is that it helps prevent a lot of addressable and preventable deaths that happen because people are scared to help somebody who is overdosing or taking them to the ER because they are worried that they might be caught in a criminal prosecution relating to a drug charge. So this was HB 158. Going forward, the Senate Bill 3617, also known as Ensuring a More Qualified, Competent and Diverse Community Behavioral Health Workforce Act, was enacted this past month, and it temporarily allows licensees out of practice for less than 5 years to re-enter the healthcare system. Additionally, the law accelerates the process for out-of-state providers to gain licensure in Illinois. One of the key advantages of this law, especially in rural areas, is that it addresses one of the major causes of a reduction in our physician workforce very directly. Aging physician population is a problem, and if we allow for our more senior physicians and providers to re-enter the workforce, it can help in preventing some of the challenges that we face with regard to the lack of workforce that we talked about. We know that rural physician workforce is expected to decline by 23% by 2030. So this law is extremely prescient in recognizing how important our senior healthcare providers can be for the well-being of the state and how this can delay the attrition in rural health workforce. The law also allows advanced practice registered nurses to conduct psychiatric visits to patients in special mental health rehab facilities, further broadening the base of the available workforce. SB 3617 also requires the DHS to award grants and contracts to enhance workforce training in specified fields. On the stigma side of things, the law creates an incentive for employers who employ eligible individuals recovering from SUDs or mental illnesses, thus helping these people reintegrate within the social fabric and maybe also keep them in remission for as long as it's possible. The final act that we are going to look at from a legislative perspective with regard to Illinois is the HB 3308, which creates pathways for increasing accessibility by creating pathways for commercial insurers to reimburse medically necessary telehealth services at the same benefits level. It also establishes a parity for virtual mental health visits and authorizes all other telehealth services to be covered through 2027. The law also addresses the challenges of transportations found in rural areas by preventing insurance plans from requiring an in-person visit for a patient before a telehealth visit takes place. On a more agency level, the Department of Mental Health and DHS have been also working to establish a student loan repayment program. We know that financial incentives such as student loan repayment programs help retain and recruit talent into previously underserved areas. And this initiative, funded by the cannabis funds that the state has, the loan repayment program, will target providers with bachelor's and master's degrees. The DMH has also launched an $8 million grant program for funding higher education institutions to recruit and train individuals working towards a certified recovery support specialist and a certified peer recovery specialist credentials. It is anticipated that this plan would add around 150 new mental health professionals to the system over the next 5 years. And the fact that these initiatives will help bring forth mental health professionals who have had lived experience with substance use disorders and have recovered from the challenges that they have faced previously. The DMH and DHS are also working to establish a new mental health professional credential to address the challenges of equity in our healthcare workforce and add as much as 500 new professionals over the next 5 years. So we've talked about Illinois. It's also important for us to look about what's happening on the federal policy space. On the federal level, CMS has instituted some of the key changes to services and site requirements for patients within its coverage, and this pertains primarily to telehealth. One major policy change that we have seen is the authorization of an audio-only care modality for mental and behavioral health patients getting care at their home provided certain conditions are met. This is a crucial flexibility for rural populations, as the cost of gaining internet at a lot of times is extremely prohibitive if you're in a really rural town. So the ability to use Zoom sort of a platform may actually force some patients out of the care coverage umbrella. So having the ability to just call your doctor through an audio only modality might actually help extend access to care for these populations who are either too rural or too poor to access internet. While there has been an expansion of broadband under the different pandemic relief programs, the fact is that these things take some time, but audio only modalities can be used currently and immediately. The policy change about the audio only modality has some requirements of in-person visits, but these can be waived depending on provider discretion. The language pertaining to the creation of undue hardship is of particular importance in the rural context, as the inability to gain transportation can create scenarios where patients may not be able to access care as easily. CMS has also created some other flexibilities pertaining to rural care. However, some of these flexibilities will sunset after the COVID public health emergency is lifted. Additionally, on the federal level, Section 304 of the Consolidated Appropriations Act of 2022 delayed the implementation of in-person requirements at rural health centers and federally qualified health centers until 152 days after the end of the pandemic. Lawmakers on a federal level have also been prescient of some of the advantages that telehealth has brought to rural communities and have instituted the Advancing Telehealth Beyond COVID-19 Act of 2022, which provides a continuation of certain telehealth flexibilities until December 2024. This law has passed the House and it's on to the Senate at this point. The legislation also delays the implementation of certain in-person evaluation requirements for mental health services till January 2021, which can again be helpful in the rural context. Now, this is the final slide this is the final section that I'm going to present. So if you're bored of my voice, it's not for too long. In this section, what I'd like to take you through is the conversations and the recommendations that the Department of Population Science and Policy has come up with after consultations with our partners in rural areas, our partners within the policy and the government realm, corporate realm, and all of those participants that TJ mentioned during his presentation about the Rural Health Summit. So, this isn't a big reveal because we release them in March 2021, but because I'm guessing you guys haven't read it, this is the big reveal of our recommendations. So, the first thing that we'd like to recommend as the Department of Population Science and Policy to transform mental health in rural Illinois is to adopt a statewide telepsychiatry program which connects rural Illinoisans to timely and effective mental and behavioral health services. The second thing we would wish to happen is expansion of the funding to rural health clinics to allow for better integration of mental, behavioral health and substance use treatment into primary care. And finally, we would really like if there's an investment in piloting and scaling new models of mental health services, especially for the children and the aging, that customize care based on individual needs and integrate these care modalities with social services. So the first recommendation, which talks about a statewide telepsychiatry program. A statewide telepsychiatry program would be transformational in Illinois. While health systems across Illinois have expanded telehealth and telepsychiatry during the pandemic, a statewide program still doesn't exist. Other states have implemented a statewide telepsychiatry program as a successful way to increase access to mental health care services. An example of this is North Carolina, which created the North Carolina Statewide Telepsychiatry Program, or NC STEP, which provides timely virtual psychiatric assessments for individuals experiencing acute behavioral health crises at hospital emergency departments. We believe that this program, if instituted in Illinois as well, could help solve the state provider crisis access issue to a degree and also generate a considerable return on investment. The second recommendation that we'd like to talk about is expanding funding to rural health clinics to allow for better integration of mental, behavioral, and substance use treatment into primary care. Integrating mental and behavioral health into primary care practice would improve services by allowing medical care providers to introduce a behavioral health consultant in real time. Behavioral health integration can increase access to behavioral health services, reduce stigma related to those seeking care, and also maximize resources at places where resources aren't available as easily. Multiple studies have shown that this process improves patients' mental health, increases patient adherence to treatment, and can also reduce costs and medical utilization in rural areas. SAMHSA and HRSA have developed a standard framework which emphasizes coordinated care, co-located care, and integrated care into the primary care practice. An example of this would be the Cherokee Health Systems, which serves rural communities in Tennessee and is a leader in primary care behavioral health integration. Cherokee embeds behavioral health consultants in primary care teams. Primary care providers screen all patients for mood disorders and substance abuse and co-manage individuals with behavioral health consultants. The primary care and behavioral health staff also have access to a psychiatrist, often via telephone and telehealth. This is of particular importance to rural areas because apart from just having a lack of behavioral health workforce, most of the doctors that we see in rural areas are primary care doctors. Seeing a specialist in a lot of rural towns is a rarity. So if we were to embed behavioral healthcare teams or consultants or providers within our primary care teams, we can reach more people and we can reach them in a more effective fashion. Finally, investing and piloting new models of mental health services, especially for children and the aging, that can customize care based on individual needs and integrate them with social services. Rural Illinois needs to invest in new models of medical and social care to improve the mental health of their communities. These models need to be concentrated along the systems of care philosophy, which creates a spectrum of effective community-based services and supports for those who are at risk for a mental health challenge and their families. Services in a systems of care philosophy are organized into coordinated networks which build on meaningful partnerships and address the cultural needs to help families function better. Illinois has been an innovator in piloting these systems of care to prevent, diagnose, and treat children's mental health and developmental disorders. The Illinois Children's Healthcare Foundation, a private foundation that funds children's healthcare statewide, is a leader in promoting this work. The foundation has invested in 3 cycles of children mental health initiatives to build a mental health system of care, and they do this by integrating mental health resources and screening at school and at the primary care level. This work has paid special attention to rural and small communities funding efforts in counties such as Adam, Carroll, Lee, Ogle, Whiteside, Livingston, Knox, Warren, Henderson, Tazewell, Woodford, and Boone counties. Based on the findings in the CMHI 1.0 report, these systems of mental health have improved levels of system integration, increased the rate of screening for behavioral and developmental concerns, and built a sustained capacity in these communities. However, these models need to be expanded to people of all ages. Illinois also needs an age-friendly health system focused on understanding and aligning the mental health care needs of aging populations. An initiative of the John Hartford Foundation and the Institute of Healthcare Improvement, in partnership with the American Hospital Association and the Catholic Health Association, has created a model of age-friendly systems focused on aligning care with older adults' specific goals and preferences. While more work needs to be done, sparks of innovation around innovative forms of healthcare delivery can be found within the state. The Illinois Department of Healthcare and Family Services has launched a $150 million per year initiative to reorient the healthcare delivery system in Illinois around people and communities. This initiative, tied to HFS's new quality strategies, focusing on the pillars of maternal and child health, adult and child behavioral health, equity, and community placement, will pilot new models to transform the healthcare system. With a strong focus on adult and children's behavioral health and funding preserved for rural communities, this new program has the opportunity to bring new models of community-centered mental health care in Illinois. So that was my presentation. Conversations and connections such as the meeting that we are in today have the potential to create a baseline from where we can start to address and transform not just mental health care but also other forms of care for our rural communities. I'd like to thank ACMI for having us over here today, and we wish you a great rest of the day. We will meet again in 10 minutes, and Donna has asked us to be really punctual. Mm-hmm. Thank you.
I just sent it to you, like,
Oh,
just
okay.
before we left.
Okay,
so.
then I will
Yeah.
talk to her if she wants to forward it. You got this.
Bring it home. Yeah. Yeah, I was trying to figure out what the issue was, but it doesn't.
It must be when you move the. Is it still off for the?
I'm trying to.
The presenter version or whatever?
Yeah, so this is the presenter version, and that's up there, but I just don't know. I don't know why it wouldn't be showing them the presenter version too. It usually does, so.
Yeah. Is yours the notes version?
Yeah, we have the notes version on mine, but I don't think I think they just see the first slide for some reason.
Zero cents. For some reason I'm not getting the slides that you sent.
Yeah.
Jody, I'm trying to find, TJ was trying to give the connection for the PowerPoints, and she tried it out the link and it didn't work. We were trying to send it out to people now. When they come back, if you can ask him to catch me, I'll kind of see if I can catch him at the door.
Yeah.
But that's what we're trying to do is to get it out so people who are virtual,
Oh yeah, I thought he sent it, but
he tried to. but it
oh,
didn't.
okay, maybe
It
the
didn't come
Wi-Fi
through.
didn't work. I might have him send it again. Yeah. Yes. Beautiful. All right, perfect. Maybe. That's just great. I know, I'm not a good crowd controller. Except I'm good with my kindergartners. I do the like clap once if you hear me, but not with other people. All right, so I hope that break was nice for everybody. I know after a nice meal, I usually get pretty sleepy, so hopefully I will not be too boring for you guys. But I get to talk about my favorite program and probably my favorite part about my job, so that's always an exciting thing. So today I'm going to be talking about the Healthy Hillsborough Project, which won the National Rural Health Association Outstanding Rural Health Program Award. And it started out as a partnership between Population Science and Policy and Hillsborough Area Hospital to improve mental health. And so just to give you a little bit more background, TJ and Vistrit did a really good job highlighting some of the health disparities in rural communities, but I just wanted to go over a few that I thought were good to highlight. So the annual adjusted death rates for heart disease, stroke, cancer, unintentional injury, chronic lower respiratory disease were all higher in rural areas than in urban areas. There's also a higher prevalence of mental, behavioral, and developmental disorders in children, with children in rural areas reporting 18.6% and urban areas reporting 15.2%. And also in general, the rate of opioid overdose was 45% higher in rural areas compared to urban areas. All right, and then the next thing I would like to, why is it, there we go. It doesn't want to stay on my slide. There we go. All right, the next thing I'd like to talk about is suicide in rural communities specifically. Now, as you can see from the chart there, overall, the rate of suicide for rural counties is 17.3, while urban counties was 11.9, and then the same trend is similar in youth ages 15 to 19, and it was 54% higher in rural counties than in urban counties. So it's 15.8 compared to 9.1 in urban. And then suicide may be more prominent in rural areas, similar to reasons why Vistrit suggested was it may be more prominent in rural areas because of social or geographic isolation, lack of transportation, lack of mental health care providers and shortages, wider availability of firearms, or the stigma of seeking mental health care services, among many others. Except the reasoning behind the suicidal behaviors and depression vary between communities, and each community is different. Not all rural areas are the same, and so that is why it's important to use a risk and protective factor approach. A risk and protective factor approach is a targeted approach that explains the differences between a high risk and a low risk individual. Now, it helps to consider factors such as community connection and things that protect people from risky behaviors, but also things that might encourage different risky behaviors. So when we're looking at these things for youth specifically, some of them are internal, and then some of them are external, like community or school or family. And some risk factors could be bullying, academic failure, their friends' use of drugs, and then some protective factors for youth could be their social skills or the attachment to their parents or how many pro-social friends they have. And I want to define pro-social because I'll use it quite a lot in this presentation. And so pro-social means anything that is good for you, good for others, or good for the community at large. So it's helping behaviors and things that are beneficial. And so one of those risk factors that I mentioned was bullying. Now, I'm sure most everyone in here or it has experienced or knows someone who has experienced bullying. It's incredibly prevalent and it can be super impactful in a person's life. Now, understandably, because of this, there was a physician that had come to the board at Hillsborough Area Hospital who had gotten a patient who had come in who had been considering suicide because the students at her school had told her she should kill herself. And that's a horrible thing to consider, especially in a small rural community where everyone kind of, sticks up for each other and knows each other. The fact that that was happening was extremely alarming to the hospital. And so, understandably, they wanted to implement an anti-bullying program. And we had a relationship with Hillsborough Area Hospital in the past. We'd implemented a child development program and a lung cancer screening program briefly. And so they approached us to help them design an anti-bullying campaign. However, we had some concerns about this because although it was really well-intentioned, because bullying is a problem and it can be a risk factor for suicide and depression, we knew that this request did not take into factor the community or the opinions of the students themselves. And so we proposed a solution, which was a youth assessment. And so this youth assessment combined the youth's actual opinion and a community-based participatory research approach. Now that's a very long title, traditionally called CBPR. This type of research approach is community-led. It's not a traditional process. Earlier, TJ was talking about how population science and policy, we don't want to just drop it into a community and just leave it. Similarly, this program sought to take the community's voice into opinion and actually do something with the community's skills and assets. By partnering with key stakeholders in the community, programs become more sustainable, they become more valid, and it also helps it to be tackled as a team rather than kind of the big research institute coming into a community and saying this is what you need to do. So then for the youth assessment, the main measure that we used was the Youth Experience Survey, and this survey was developed by the Annie E. Casey Foundation and the Social Development Research Group. This is a self-reported measure, so it's students reporting on their own behaviors. It's not their teachers reporting on their behaviors. It's not their parents reporting on their behaviors. It is their own report of their behaviors, and it looks for risk and protective factors for the youth. Now, this is normally administered in just grades 6th, 8th, 10th, and 12th, but we wanted a little bit more of a comprehensive approach. And so we conducted the survey for the Hillsborough Junior High School and the high school, which is grades 6th through 12. We also included 2 depression measures and a measure of students' relationship with their parents. Now, some example questions from the Youth Experience Survey are: how often do you feel that the schoolwork that is assigned to you is meaningful and important? And then if you skipped school, would you be caught by your parents or caregivers? And those 2 questions kind of highlight some of the risk, that they help identify some of the risk factors that are within a community. Now, our youth assessment was broken up over 2 separate days because the school had input and the school didn't have a class period that would have been long enough for the students to take the survey in one day. We split it up into 2 days. Now, the first day consisted of 97 total items. The students took an average of 33 minutes to complete, and there were 736 students total that completed it on day 1. And then on the second day, it was 57 items. It took an average of 18 minutes, and there were 649 students that participated on the second day. But in order to maintain anonymity, because we were asking students some very serious topics about depression and suicide, we created a unique ID system in order to link the data from day 1 to day 2. Because if we would have had to have names with an ID number, that would have been a confidential survey, but not a anonymous survey. But in order to maintain anonymity, we created this ID system where students would select a number corresponding to their first letter of their middle name, the day of the month they were born, the day of their month their oldest sibling was born, and then their favorite color. And because of that, a total of 395 responses were able to be matched from the first day to the second day, which was a 60% matching rate, which doesn't actually sound like that much, but I think it was pretty impressive because of the fact that it was a completely new system that we generated to match those IDs. And then there were also honesty checks within the survey implemented. So honesty checks were things like comparing monthly to annual frequency of drug use. So if a student, for instance, said that they had used alcohol 30 days in the past month, but then they had said that they only used alcohol 1 day in the past year, that would indicate that they were not answering those questions honestly. There was also a self-reported honesty questions. We asked if students were honest in the survey. And then we also had a question that asked if they used a fake drug that was made up. And then for our findings, we broke them down into 2 types of analyses. The first type of analysis was cut point analyses, and these are age-specific formulas that determine the threshold for the level of risk that it poses, or the level of protection. So for example, smoking 2 cigarettes during 12th grade is a different level of risk than smoking 2 cigarettes in the 6th grade. And then we also used regressions, so that involves using a statistical program to determine which risk factors or protective factors, which risk factors determined depression and suicide, and then which factors protected youth from suicide or depression. And then, so this is a table of the junior high protective factors. And so if you can see on the top left there's a smiley face. So if it's a protective factor, that means that it's good, that is higher. So some areas where the junior high students had higher protective factors were neighborhood collective efficacy, and parental involvement in education. And then you'll also see these diamonds on the screen, and that is a national comparison number. So the Youth Experience Survey has been implemented in several other schools, and there is a database of national number comparisons, and so we were able to compare each of the students' results to national numbers. So some areas where it was higher than the protective factors were higher than the national numbers were opportunities for pro-social involvement in the community and social skills. But then there were some areas that were a little bit lower, and 2 of the most concerning were school opportunities for pro-social involvement and school recognition for pro-social involvement. So that's students not feeling like they are rewarded for good things at school, or that there are opportunities to do good things at school, even if that is things like clubs. And high school students showed a very similar trend. The higher protective factors were parental involvement in education, and then neighborhood collective efficacy. So that's feeling like your neighborhood is willing to come alongside you and show support for you. And then some areas where it was lower than the national comparison were school opportunities for pro-social involvement again, and then pro-social friends. So that's friends who are doing, good behaviors and practicing helping behaviors. And then for the risk factors, so this table can be read in an opposite way. So if something is higher, that means that it is a negative thing that it is higher, and if it is lower, that means that it's better. So some risk factors that were higher and above the national comparison were low commitment to school, family conflict, parental attitudes favoring antisocial behavior, and being a victim of bullying. And so bullying was a problem in the junior high. And then some areas that they were doing better than the national comparison, however, were early initiation of drug use. So students were not necessarily using drugs as early as the national comparison. And then for the high school, it was a very similar sort of trend. The low commitment to school was still very high. The parental attitudes for favoring antisocial behavior were also high. But then there were lower ones, such as past grade retention, so that's students who were repeating grades. And then friends' gang involvement was also very low. And then, like I said earlier, we had 3 separate depression measures on this survey. One of them questioned whether students had considered suicide in the past 12 months. And in this school of these schools of 600 some students, 1 in 5 youth had considered suicide over the past 12 months, which is a really alarming number. More high schoolers did consider suicide over the past 12 months, with 22.1% over the junior high's 16.6%. And then one of our other depression measures was asking if the youth had abnormal levels of, seeing if levels of depression and anxiety that youth had. So 1 in 4 youth reported having abnormal levels of depression and anxiety. And similar to the one before, the high schoolers had higher levels of abnormal depression. And then in the last depression measure, it was a clinical depression measure, and 12% of the youth registered as having severe clinical depression. And for this one, it was actually it was, I believe, high, yeah, I think it was, no, hold on. It was higher for the junior high than the high school, sorry. I was reading my table wrong. And then as far as some of the conclusions goes, the middle school risk factors or the junior high risk factors were low commitment to school, bullying, and family conflict. And then similarly, the high school had those same risk factors, except they also had low neighborhood attachment, transitions in mobility, and academic failure. So this shows that the hospital was not altogether wrong in assuming that bullying was an issue in their communities. However, there were other issues such as the low commitment to school and family conflict to be considered. And then as far as protective factors, the junior high protective factors were family attachment, rewards for pro-social involvement in school, and academic self-efficacy. And the high school factors were very much the same, with the addition of opportunities for pro-social involvement with family. Now, after we got these results, something needs to be done with it, of course. So in the winter months of 2019, Rex Brown from Hillsborough Area Hospital and Amanda Cunningham, who was a school counselor at the school district, started recruiting potential steering committee members. Now, the goal of creating the steering committee was to create a diverse group of decision makers to share perspectives and decision-making power regarding youth mental health programming. So it was designed to be interdisciplinary, balanced for gender, and included parents and youth. Finally, it was designed to have an odd number of individuals so that voting could be more easily determined. The first meeting was on February 12th of 2020, and they created their own mission statement. We did not create their mission statement for them. They were able to decide what they stood for and as a committee and what they wanted to do. So their mission statement was to improve community engagement and positive behaviors resulting in improved youth mental health, make evidence-based decisions guided by community-driven data for youth, and maintain diverse membership to leverage each person's unique background and sphere of influence to address the true scope of our community's mental health status. And then we have some pictures of our steering committee. So the committee consisted of 9 voting members originally. There were additional non-voting members to help with administrative tasks, but they had no power to vote. And they were all asked to provide a favorite picture so that they could show who they were. And then they all resided in Hillsborough. It consisted of a retired sheriff, a pastor, a school superintendent, a school counselor and business owner, 2 youth, and 2 parents. At least 1 member of the steering committee was a non-native English speaker, and at least 1 openly identified as part of the LGBTQIA+ community. The school counselor was also invited to serve as the chair, and the hospital also provided project management to help coordinate monthly meetings, and they also provided a space for us until COVID-19, and then we switched our meetings to virtual meetings, and we have been virtual since. And so after we created the steering committee, we needed to select programs. Now at PSB we use several different ways to select our programs, but one I actually wanted to highlight for you all today is Blueprints for Healthy Youth Development. This is one of the most useful tools that I think is out there for finding evidence-based programs related to risk and protective factors. This tool was developed by the Annie E. Casey Foundation and summarizes information about programs as their degree of evidence. It gives articles of clinical trials. It shows you the age ranges that students are supposed to, that the programs target. It also shares the program setting and even some costs. You can go on there and select specific risk factors that the community has, and then search from there different programs that would be beneficial within those for that community. So after we searched for programs, we recommended 3 separate programs to the community. It was the Blues program, the Strengthening Families program, and the Sources of Strength program. And I will explain all 3 of those. And so the steering committee actually, when they first wanted to vote, they wanted to vote for all 3 of the programs. They were really excited about all 3 of them, but as the hospital was providing the seed money to begin all these programs, they didn't think that they could handle all 3 at once. They did, however, allow the steering committee to select 2 of the programs to start in 2020, and then possibly implement the 3rd if more funding should arise. So the first program that the steering committee selected was the Sources of Strength program. This program connects adult advisors with peer leaders, and they work to influence their other peers' attitudes and beliefs about mental health. This is a universal prevention program, meaning it is for all students, and so all students in the school are reached through this program. And the program really highlights different areas of strength that help us to cope better. And so some areas on their wheel are generosity, spirituality, physical strength, health, mental health, family support, positive friends, mentors, and healthy activities. Now, a lot of these align really well with the protective factors that the both schools were high in, and also highlighted a few of the risk factors too. And so this program started in November of 2020, and it started in just the high school, and 31 peer leaders participated and 39 adult advisors participated as well. And then in the second year of the program, it expanded to the junior high as well, and so there were 76 peer leaders and 74 adult advisors. And so each peer leader, they meet monthly with their adult advisors. They usually meet as teams in both the schools. Sometimes they meet as large groups, and they talk about different activities that the groups can be doing to promote some of these areas of the wheel. So whether they're promoting mental health or physical health, what are some messaging campaigns that they can use with their peers and with other students to help improve the overall culture of the school. And so some of the really cool activities that the students came up with themselves were a school-wide Easter egg hunt. They invited guest speakers to come in and talk to the peer leaders. They had TED Talks where the students would talk about different aspects of the wheel. They had chalk contests. They had a talent show. They had a band performance where they performed a song for a musical that they had created to highlight the importance of mental health. And then they also took a school-wide walk where they highlighted those physical activities and good things to do for your body, which I think was really fun to see the students take that initiative and take those steps. And then the next program I want to talk about is the Blues program. This was the second program that the steering committee selected in 2020. This program is a intervention program. So instead of being for all students, it's only for select students. And this program is for students with depressive symptomology or who are at risk for major depression. It focuses on teaching them new behavioral strategies and developing different response plans for life stressors. So we actually utilized a screening that was already in place in the high school because this program is only for high school students. This program is only for high school students. And so we use the behavioral and emotional screening system that the high school already implements, and we found the students who were at risk, and those students were invited to participate in the program. Year one of the program, 20 youth participated, and there were 3 facilitators. In the second year of the program, there were 11 youth and then 1 facilitator. And there were a lot of COVID-related difficulties in the second year, just due to masking guidelines in the school. And so there was a little bit less youth who did participate. But this next year, the creator of the Blues program has actually shortened the length of each session so that it can fit within one class period. Because one of the complaints that students who had been through the Blues program had was that it took up too much class time. They were missing not just one class, but one class and about a half of another class. And so the school approached the creator of the program to sort of look for a way to implement it just during one class period. And so he was able to do that, and so they shortened it to one 45-minute class, and then they will implement that into their like social learning class. They have a social learning class that all students in freshman year and sophomore year have to go through. And so any student that wants to in the school and has permission from their parents can now be a part of a small group for the Blues program and get out of class, not really get out of class, but they can leave class and go to this program, but then they will still get credit for their normal coursework. That will not count against them. Now, this doesn't really help the older, it does help the older students a little bit because then they are only missing one class, but as this program continues, so right now the juniors and seniors will still have to miss some work, but as the program continues, it will hit the freshmen and sophomores before they become juniors and seniors. And so hopefully there will be less class missed overall and less credit missed, and the students will be willing to participate even more. And then the third program that is being implemented in Hillsborough is the Strengthening Families program. Now, this program was not initially selected as a program to be implemented, but it was kind of the hope of the steering committee that this program would be implemented in the future. And due to a grant from the Illinois Children's Healthcare Foundation that we helped them apply for, but also the community helped writing that grant, that we were able to get the funds to start this program. And it's also being implemented with a faith-based organization in Hillsborough called Crossover Ministries. And so they have a set-aside space for families to come and be a part of this program, which it's a skills training workshop, and so parents come and they are there for an hour and they learn different skills like teaching your kids like boundaries and monitoring your kids, and then youth learn life skills and refusal skills, and then after that hour of separate classes, both parents and youth come together for another hour and learn those skills together and talk about what they've learned, and it helps to strengthen family bonds. And there's also a free meal provided to every family that comes, and childcare provided for every family that comes. And then there's also a little bit of a money incentive for the first few families that will be coming to this program, and that's set to start in the fall of 2022. And then we do have some program evaluation information. So we've done pre-tests and post-tests for both Sources of Strength and for Blues. We haven't been able to complete that for the Strengthening Families program yet because it has yet to begin. However, the youth peer leaders had more favorable attitudes towards seeking professional mental help than the other non-peer leader students, and they also displayed higher pro-social behaviors, and as you remember, that's helping behaviors, and they showed higher empathy and lower suppression. Now, suppression is taking your emotions and kind of bottling them up rather than dealing with them and reappraising or evaluating them and dealing with them in a healthy way. And then students also displayed higher pro-social behaviors and tendencies in the post-test than they did in the pre-test. And then the Blues, as I said, it was only a sample size of 11 and 20, and we weren't able to get any statistically significant results from this. However, students shared that the program really helped them to feel better and learn new coping skills. And then I have a video to share about the program, and we'll see if it actually works. We're gonna hope it does, but if not, we'll move on. That's okay. All right, well, it's a video explaining our programs, and we're going to send out the slides, so if you would like to watch it afterwards, or you can watch it on our website under the Hillsborough Area Hospital section, under the David A. Imler Project. I think it's playing. Anyway. All right. And then, so we also have plans to expand this program to other communities. Now, Hillsborough Area Hospital is also funding this program in Nokomis, Illinois, which is about 20 minutes away from Hillsborough. And then we, as PSP, are also completing a similar process in Mount Olive, Illinois, and then Alton, Illinois. And then, as we've had so much success this past few years, there are some things that we do want to keep in mind as we continue and work on these type of projects. So the first thing is time. So we need at least a 2-year commitment for baseline data collection, program selection, program implementation, and evaluation. And then also with program selection, it's very important to have remote training options and remote implementation. If there's one thing that COVID-19 has taught us is that having things that are able to transfer to remote is incredibly valuable. And then also options to license to save money. So for example, the Sources of Strength program actually has a Train the Trainer program where a trainer can come from the school and they can be certified to train the students and the adult advisors, and that way the school would not have to pay for a outside trainer to come in. That you can just have an in-house trainer who's already trained. And the school has actually had 2 representatives take the Train the Trainer program, and they're working on getting certified as trainers. So in the next coming years, hopefully when Hillsborough needs to train students and peer leaders, they won't need to spend so much out of pocket to have a trainer come and teach them the Sources of Strength program. And then other aspects to keep in mind are utilizing existing systems and skills. So utilizing school screening systems like the behavioral and emotional screening system, and then considering also who has skills to contribute. So like Adobe or finance or writing, one of the things that happened the other day that was kind of amazing was we had this brochure that we were just having the hardest time figuring out how to not be blurry, and one of the community members fixed it within 2 seconds, and I was amazed because usually I'm the person that does those types of things. And so it was beautiful though. It was like, wow, I'm glad that there's someone who can do this. So just utilizing skills that the community does have, and then also considering different areas of funding. So community benefit through the USA Patient Protection and Affordable Care Act, and then COVID release funds like from the Illinois Children's Healthcare Foundation. And then I have some questions actually for the audience, and then you guys can ask us some questions. So what are some challenges your organization has faced in regard to mental health work?
Probably workforce. A mental health provider, gets them at the entry level often, but then they need to work for larger agencies or go in private practice. And that goes along with the wait list of people in the community that's growing a lot now.
Did anyone else have a thought on that one? Yes.
Is this specific to rural areas or?
You could say anywhere.
So I live in a rural area for 14 years,
Okay.
14 years that I was happening, it was pretty horrific. And so there's no services there, and like the lack of privacy, like everyone knew everything, and so it was very bad to move away.
Absolutely.
Like the access,
Yeah.
and then really because of that happened, why they long,
Yep.
particularly for children. I mean, I know for everyone, but children really it takes 2 hours to do many things.
Yeah, it's crazy how many most specialties are either in Springfield or St. Louis. My husband's a pediatric gastroenterology nurse, and it's weird when you have somebody who lives not by St. Louis or Springfield, but that is the only place that they can go just for this specialty. So,
I would also say there's kind of the opposite, like we have a newer, child psychiatric program that is way underutilized.
oh, okay.
But then like,
Huh.
the mental health needs for the kids, like in this, like, as reported by the schools, like the kids are not doing well at all.
Huh.
So it's like, I don't know if this program's not really marketed, or people just don't know about it, or like it's the stigma of it is
Hmm.
way underutilized. I don't know.
Yeah.
Yeah.
I'd
Yes.
like to add to that, the whole component of identification and resources. Yes, just basic, community mental health education is extremely lacking. I mean, that happens in our community too.
pretty data. And so we have schools who, because of the increased request for mental health services and because of some of the increased symptoms that are being reported, you have schools who are willing to sort of step, embed some people from community mental health agencies to provide services. However, there's really not a good buy-in in terms of coordinating the system or having them be okay with the planning. So I think that's a challenge for us, is that the school and mental health system remain entirely siloed.
Yeah. I think that was one of the Rex Brown, who's the CEO. He always calls it like feathers. You know, he says that feathers are like flying is like when something good happens, but it's just like it was amazing how much cooperation we had from the schools and from almost everyone in the community was on board and ready for these programs. And you really do need that buy-in, or else it is just going to have that silo. So what are some mental health solutions or changes that your organization has been able to implement where you are?
I just want to mention regarding the schools, one of the things that we have is what we call school protection teams, where we work with social workers of all the different schools in the county and with behavioral health professionals, and we meet quarterly. It was done in person prior to COVID, and now it is virtual, and really virtual is probably best.
Yeah.
Traveling and so forth. But that's worked out really well
Yeah.
for schools and behavioral health folks to be on the same platform and learn. A lot
That's
of it
really
is about schools not knowing what the resources were, how to
Yes.
access them,
Yeah.
and so forth. And I know I'm not in that typical rural community, but that is something I think is beneficial, that I think is working out.
How many people do you usually get for those meetings? That sounds really cool.
It's probably about, it's over 100.
Oh, wow.
It depends. It's over 100 because it's behavioral health professionals and school
Okay, yeah.
professionals.
That's still awesome. So cool.
Oh,
Oh, yeah.
Mental health first aid,
Okay.
is actually being offered, I'm getting ready to teach, an entire school district, their support staff,
Mm-hmm.
and they're gonna do it over the school year.
Okay.
And so I'm gonna be interested to see with the updates that the National Council has done,
Yeah.
will this be impactful on the, showing like the different signs and symptoms
Yes.
and how to work
Yeah,
with young
absolutely.
people.
I was just gonna say, not to supersede your.
No, you're good.
We have a limited amount of time left.
Do we?
I just wanted to know
Oh, yes.
if we could open it up.
Yes, we can totally open up for questions. Yeah, that is absolutely
So
perfect.
we have about 10 minutes before another
Here too,
program,
yeah.
I think is coming in here.
I didn't realize it was late.
Thank you.
Thank you for checking me on the time.
Yep, that's okay.
And then, yes.
I have a question, for the rural, presenters. Have you all assessed or talked about like the industries in these rural areas that have left? So what I am noticing is that these areas were not all in rural. It was turned into rural spaces when those industries left. Those industries were actually providing resources to those areas. They're not there anymore. That is a conversation that I have not heard, brought up in any of when industries leave. What is the plan of action to actually provide supports to those families that are left behind because that industry has left?
You guys hear me? Is this on? All right, is that better? Okay, we're on. Yeah, so that's a great question. We ran into it in a couple communities that unfortunately had the same question, but they didn't have the answer either. And I think it's got to be more so from a federal level. So, for example, one of the communities we have was in southern Illinois, Sandoval, not Sandoval, but Sandoval. They made sure to correct me. And they had a zinc smelting plant that was their big, job creator where everybody worked in the town. And when that plant went under, so did all the jobs. And when we talked to a lot of the kids in that talking about is what is like the despair that even the kids in the high school talk about is, well, you know, yeah, I can't go to college because mom or dad didn't. The only you know, way out I have is the tire factory. You know, it's 30 minutes west in another town. And it seems like there's nobody really doing a lot of work on replacing either, you know, like manufacturing jobs that, you know, the factory is closed and, like you said, either the town dies and people move out, or the people that are left there in many cases are, you know, left behind. And I think one of the solutions that I think a lot of people immediately jump to is, oh, telehealth. Just hop on the computer or on your phone, and you don't have to worry about it. But like you're talking about transportation, like if it's for your child, well, it's not just get your kid out of school. It's you taking off work. You may take a whole day. Well, if your supervisor doesn't let you do that, then this kid is not go to the appointment, and you never get them help. And then broadband, right? I'm sure if any of you are in rural areas, if you have it, it's incredibly expensive, and most of the time you aren't going to have it. You're going to have like satellite, like HughesNet or whatever. I think my cousin had that. If it was cloudy, she didn't get internet. So being able to actually access services, period, is tough. But then, like you said, when the town goes under, and even if it's not like a manufacturing, if the hospital leaves, if the hospital closes down, what a lot of the research shows is so does the town, so does the community, right? So that is like the main economic driver of a lot of those towns and counties.
I wanted to add a point about the hospitals that you take.
And I'm wondering, can that start being in the conversation, like a whole lot more? Because you might find out that before they leave, they might be willing to even invest or see what types of resources can go into that community.
So that's a conversation that our former chair, Dr. Smearmore, who's now the director of IPH, him and I have a
because you can obviously make more money in cities like Chicago or St. Louis or one of those places. So what is the real incentive of driving you to stay in that community? Loan repayment can only go so far because a lot of times these loan repayment programs have a sunset period of like 2 years or 3 years. And once that sentence or like that duration is over, what keeps you there? And that's why like co-locating with the community, having the ability to be considered an important member of that community will be really important.
We are pretty much out of time, so I did want to just stop and say thank you to our panelists very much. And if folks have some other further questions, I'm sure you can email you folks, right? And bring your presentation. And if other people are interested in maybe continuing the conversation about rural, I would say if you would like to Jody here. No. Yep. Yeah, if we could, let Jody know that maybe there's another way to form these, that those of us who talked a little bit about maybe having the informal Zoom meeting to continue some of the discussion about rural health. So thank you everybody for participating.
Hi everyone, we are just switching out here, so bear with us. We will get started here in just a second.
Thank you.
Hi, Mark.
Hi, Cheryl. How are you?
Good. How are you doing?
Great. Nice to see you.
Good to see you as well. Been a while.
Yes, it has. What are you up to these days?
So I'm the executive director of the Oak Park Community Mental Health Board now. So,
Great.
yeah, I left the Kennedy Forum about a year ago. So, yep, it's been nice. I'm in my hometown now. I don't have to commute.
Great.
How are you?
Fine. Fine.
Well, good to see you.
Okay, so hello. I don't know if it works. Can everybody hear me? Oh, there we go. Hello, I think we're going to get started. We have some folks online. Our roundtable discussion today, we are hearing from Mark Harriman. He had contacted us with the Mental Health of America. He's going to speak to us today about a data mapping project and share with us his presentation. So with that, I will hand it over to Mark. So thank you.
Good afternoon. So I am Chair of Public Policy for Mental Health America of Illinois and a member of its board and also facilitator of the Mental Health Summit. What I'm planning on presenting to you today is a resource which I think may be helpful to all of the community mental health boards across the state. And we'll do a brief PowerPoint presentation to talk about that resource, and then I will share that online resource, which any of you can use at any time. It's available on Mental Health America, our national organization, created this resource, and anyone can use it at any time. It's a website data portal that shows mental health needs across the entire country, but by county, and we're hoping to break it down by zip code. So let me start with my PowerPoint presentation, and then we'll go forward from there. So okay, so in 2014, Mental Health America, which is our national organization, Mental Health America has been around for about 110 years. It's present in almost 40 states, and Mental Health America of Illinois is its Illinois chapter, which has also been around for more than 110 years. So we created a mental health screening program that is available online, and you see the website there where you can go to that screening site. What that screening site does is to give free, anonymous, evidence-based screens for 11 mental health conditions. 2 of the screens are available in Spanish. So here are the available screens. Anxiety and depression, those are the two that are available in Spanish as well as English. Then psychosis, post-traumatic stress disorder, attention deficit hyperactivity disorder, postpartum depression for new and expecting parents, bipolar, addiction, eating disorder, youth mental health, and then there's a test that parents can take on behalf of a young child if they are concerned that their child may have a mental health condition that needs attention. And so these are all evidence-based tests that are been available and are free to anyone. But what we have done is to create a website where you can take them online. So what has happened with these screens? So we collect, in addition to collecting the results of these screens, anonymously of course, but we ask people to give us a bunch of answers to a bunch of other questions. You see the demographic questions that are asked: age, gender, race, ethnicity, household income, state, county, zip code, and then some treatment questions, whether the person has been previously diagnosed with a mental health condition, whether they've gotten help before, applied to, whether they have health insurance, etc. And then we've asked some specific demographic questions about that we think are important to, in general, to persons in need of mental health services. So we were lucky to get some financial support from Lundbeck, which is located here in Illinois, in Cook County, and they have given us money to help deal with what data we could derive from these screens. And again, we can just derive data. We don't have the names, and we have no intention of trying to get the names of anyone. These are just anonymous screens that have yielded a great deal of data. So in the beginning, when we started in 2014, we were just getting a few 100,000 people a year. And then we began to get more people. And since the pandemic started, we have got more than 6 million people in the United States have taken this screen. And what we then decided to do was to create a screening data portal. And I will show you that when I'm done with the PowerPoint presentation, where you can look at your county and see what the unmet mental health needs are in your county. And then we are working on getting that down, at least first in Cook County and then elsewhere, down to the zip code. So as a result of this screening data, we have published the reports you see there on suicide, on depression, on trauma, on psychosis. And you'll be unsurprised to hear that due to COVID, all of the screens for these conditions have increased substantially. And you can go and look at these screens and download them for free on the website that's listed at the bottom of this page. I believe you all have printed copies of this PowerPoint presentation, so you can go take a look at those reports if you wish. So what did we do with the data? We created this data mapping dashboard, which is this free online portal to the data. And it's the first thing of its kind that has ever been created in the United States that really has real-time mental health data. So people, a huge number of people are taking these screens every single day. And we update the portal at least once every 90 days. We have on the portal data from 2021 and the first 2 quarters of 2022. We will put up the 3rd quarter of 2022 once, probably within a month after it ends. And we haven't put everything up there because this is quite a project, as you can imagine. So, but we have put up the results from depression, suicidal ideation, PTSD, trauma, and psychosis at both the state and county level. And that's the link to the data portal there at the bottom. And again, I hope you have this printed so you can look at the data portal whenever you want and look at your county to find out what the needs are in your county. So you can, I'll show you, with a little luck, I will show you how to use the portal once I'm done with this presentation. So what are the important findings? So 76% of the people who have gone online to take screens showed positive symptoms for their chosen screen. So you can take all 11 screens if you wish, although they won't all be applicable to everyone. You probably can't be both a parent and a child at the same time, although that sometimes occurs. And so obviously you need to understand that the screening is not a perfect reflection of the world for a variety of reasons. And that's because it's only people who've chosen to go online. Most of the people who come to Mental Health America's website to take these screens are people who've just done a Google search for mental health or mental illness or screening or testing and have somehow come to our website. And so one of the other important finding is that 66% of those people who have screened at risk have never before received or sought mental health services. So I think we are catching a population before they have probably before they have gotten so sick that they need help, but they may need help, but they have not gotten it. And it's people who we could intervene with and try to prevent them from getting sicker, if that's the likely course of their illness, or from needing more attention. So this screening data identifies unmet need, but certainly need that is urgent. Now, again, part of the problem is just because who goes online to seek help? And the answer is it's more apt to be young people. People who are young are more apt than perhaps someone like me to go online to look for healthcare services. And more women than men have taken the screens because women are more likely to seek help for mental health conditions. That may just be a testament to women being smarter than men. I have no opinion on that, but or maybe men being reluctant to acknowledge their mental health conditions. So just coincidentally, the screening results from Cook County resulted in its ranking as number 3 among large counties at risk for suicide, severe depression, and PTSD. That's one of the reasons that we are now embarking on a special project for Cook County, which we hope to be a model for the rest of the state and for the rest of the country, thanks to some support from Lundbeck, as I mentioned. So how can Illinois use this data? So if you're a legislator, you can use this data to advocate for increase for services in your district. So you can look online and see which counties have the most unmet need for various kinds of mental health services. It should be helpful to both the Department of Healthcare and Family Services, who, as I suspect you all know, runs our Medicaid program, and to help them make sure that there are services in the counties and other areas in the state that have the greatest unmet need. And of course, the Department of Human Services, who also funds mental health services and runs our 7 remaining state psychiatric hospitals. And of course, county and city health departments. This can set priorities, and they can also be advocates. We have data for young people, so it can also demonstrate to educators where there is a need for student services. One of the things that MHA, the national, is doing is now working with school districts around the country, or just beginning to do that, frankly, to ask them whether they want to do this screening for everyone who's in their school, if they wish to. Again, and that's it's really that school districts, having learned about these free screens, have reached out to Mental Health America. And then, of course, community mental health authorities can use this to determine their priority programs. How should they be spending their money? What are the greatest unmet needs in their area? But also, community mental health authorities are often advocates for other funding. And as I suspect everyone in this room knows, there's business just in the last few weeks. We've rolled out the new national 988 mental health hotline. And of course, that is intended to have 3 separate prongs to it. The only prong that is we can say is really in act fully implemented, if imperfectly, is that there's a number to call. But the second two prongs is to make sure there's a person to send when that's necessary. And we can, again, think about where we are most likely to need those persons. And then a place to go if a person to send is insufficient and the person needs to go to get services somewhere. So what are the other policy implications? So one of the things that we have found from our data is that the thing that people want the most is to talk to someone else. That may include, of course, a mental health professional, a psychiatrist, a psychologist, a social worker, a counselor. But it may also, many people want to talk to someone else who shares their condition, particularly people who go online for services. They just want someone to talk to who will be sympathetic and have some experience. And as I suspect everyone in this room knows, peer services have been researched and shown to be effective at helping people with mental health conditions, and they're also highly cost effective. And Illinois already has some access. We have Medicaid reimbursement for peer services, and we also have a state-operated program to train more peers. So one of the things that perhaps one can think about in terms of how do we respond, we don't have I doubt that anyone says, oh, I've got all these extra resources and I don't know what to do with them. But if we start thinking about how we can respond to this unmet need, this seems to me to be one of the ways that we could do more quickly than trying to find more mental health professionals, which, as everyone knows, are in short supply these days. Excuse me. So, as I said, I will show you how this dashboard works. And that's available to anyone in the world who wants to go online to look at it. And it provides data by the county and by the state for every county in the country. But we are now beginning, we are just in the beginning of this, to do a special project just in Cook County. And we have, Mental Health America has gotten this funding and has now is beginning to break down Cook County into zip codes so that we can say, for example, that the places where the greatest needs in Cook County are particular towns or townships and cities or parts of cities by zip code. And we're in the process of planning to convene local providers, advocates, government officials to create a county action plan based on the information that we have from the screening site and with the input from all of these people who care about the mental health system. So we hope to create a process that can be used across the state and across the county for high-risk counties to better allocate their mental health services. So I'm going to stop here with this. And before I go to, and then I will show you a website, but if anyone has questions at this time before I go to the website, now is the time to ask them.
I have a quick question. If someone were to go on there and indicate, just say depression, something like that, significant depression, at the end of it, they put in their zip code or their county, does it direct them to any services or encourage them to seek out services?
So I think I heard that, but the sound is extremely faint.
We had a question as to whether or not they clicked on depression and whether or not it was taken to services available there in the community. Is that possible?
So on the you're now looking at the data portal, but on the screening website, which is a separate website, that's where you can go and take a screen. There are links to talk about different services, and to the extent that we have gotten organizations who want to participate in this, we are happy to link people to local services. So that's still a work in progress. So what's available on the website is largely generic, but also some particular places. So, and we do not, so people can then use that website to connect to those services. But that's still a work in progress. Mostly what you will get from being screened on the website is that, in fact, you have screened positive or not for a particular condition, the list that I provided earlier.
Hey Mark, regarding local resources, probably one of the best things I think would be maybe connecting with 988, because then it would get to the local resources. So that would be a great way, because I think I can see us really promoting this.
Yeah, I can't hear whatever's being said.
Yeah, and then knowing that there's services at the other end would be wonderful.
I'm sorry, the sound is extremely faint and I did not hear that question.
Can you hear me?
A little better. Can you speak up?
I was just making a recommendation of connecting this to 988. If people wanted local resources, that might be the best way to do it. That way it gets to our local resources in our area.
I think that this national organization will be putting information about 988 on the screening website, but they have not done so thus far. I think that's an excellent idea.
Anybody online that had questions as well? Oh, I'm sorry.
I wanted to know if someone took the assessment, is there a way to determine if they're currently receiving services for something? If perhaps they're receiving some counseling for PTSD, but they decided to take the assessment in some other category. Is there some way to see the data of the people who are receiving services versus the ones who are not?
We do not collect that on an individual basis. We have just connected it, and I'm not sure that we have the capacity to do that. I think, and again, we're not, at no point do we plan on revealing to anyone, a service provider or anyone else, in part because we don't have this, who the identity is individual people. So the only thing that we can do with the data is to say, look, we've asked everyone this question, are you getting services? And this is the percentage of people who say yes. We could probably, but we have not yet done this, say, okay, of the people in this county who screen positive for depression, what percentage of them are currently getting services? But we don't ask them what, our questionnaire does not ask them what kind of services they have gotten, because we don't want to burden people with too many questions. And we simply wanted to, for this purpose, we wanted to give people some basic information that they have a mental health condition, one of the 11 we're screening for, and then there are, on our website, you can look at it, there's all kinds of ideas about different services that may be available and how you might get them. But not the level of specificity that you're asking.
One more question.
Is there discussion on adding more categories or target areas? For example, I know in our As you stated in here, that women take the survey more. We're really wanting to target men more because both our overdoses and our suicide rates are predominantly men, as all the statistics also show. So are there ways that you've thought about targeting men to take the survey? And is that something that can be done in the future?
Can you repeat that question? I really cannot hear you.
They're asking if there's ways to target men in the survey.
The way to target what?
Men. Gentlemen.
But I'm not hearing that word. A way to target what?
Ways to target men, M-E-N.
Oh, men. Okay. So again, we collect data on that. So you can look to we know gender and age range. Yes. So the answer is yes, you can do that. It isn't available on the portal yet, but it will be. So you can find out.
How to reach out to men. Are you guys targeting them specifically?
Oh, we're not targeting anyone. So the way that this screening website, overwhelmingly the people who come to the screening website come to it completely by doing a Google search. We have not advertised the site other than to do programs like this. We've done a bunch of webinars across the country announcing that we have screening and announcing that we have the website. But we lack the resources to do like a TV campaign or some other advertising campaign. So the people who have taken the screen are simply people who have somehow found our website. And what we've found so amazing is that the numbers have grown so substantially, so that now more than 12 million people have visited our website since we created this screening. And it's increasing it continues to go up, even though it started to go up dramatically during COVID, but it has not gone back down. We don't have an advertising budget. So unless there are other questions, I would just give you a little tour of the portal and to show you how you can use it. Is that okay?
Yes.
Okay. So this is the portal, and just to show you, what I did was to press the depression button, and you can see there are the conditions across the top. So you can press one of those buttons, and then what I'm doing next is pressing county, and we'll next and then we're going to look at only Illinois. So if you press county, then you see these are counties across the state. If you see the map, but look, you can hover over any county and get data. So here's LaSalle County. The number of people scoring with severe depression per 100,000 of the county population was 82.1. The total number of responses was 243, and the county population is 110,000. So you can hover over any county. There's Macon County. And I think now it might be helpful to go to Illinois, and so now you just have ranked here in that column, the highest percentage of depression per 100,000 ranked down to the lowest. So, so from Bond, which has the lowest, to Mosaic, which has the highest. And you can, again, hover over any county in Illinois and find out, here's the page, and find out what the depression responses are. And you can find that out for any county. And if you are not interested in depression, or you're interested in something else, you simply go up here and look at suicide, which is a subset of the depression screening. And you can look at suicide, again, down to the state, only for Illinois. And for suicide, the highest county is Wabash, and it goes on down. So you can find this data for any county in the state for any condition you have. Now, what we're beginning to do for Cook County, as I said, is to break this out by zip code. I don't have that available for you today, I'm sorry. And then to also look at other questions, like to look at age and gender breakdown to see where things are. So one of the things, since I have seen some of this data, I have seen is that, unsurprisingly, suicide and depression is highest in the zip codes where there are colleges and universities. And some of those zip codes are otherwise pretty well resourced and pretty well off financially. But I just took the liberty of looking at Evanston, which has the fairly well-known University of Northwestern. I looked at Hyde Park, which has the University of Chicago. I looked at Lincoln Park, which has DePaul, and they all have higher rates for depression and suicide than than much of the rest of the county. And one assumes that that's because there's a university there. So are there questions about how to use the portal?
No questions here. Anybody online?
So to conclude, I would just say that, Mental Health America of Illinois would be happy to work with any of the 708 boards or any other organization in Illinois to think about how the data can be used, how it can be used for planning, how it can be used for advocacy, how it can be used to make the mental health services in your county, township, city, or area as responsive to unmet needs as it can be. And my contact information is on the last slide. So I'm happy to talk with any of you, send me an email. And I look forward to working with you to help this as good as it can get.
Thanks, Mark. And for those online, there's a copy of the slides on the link for the business meeting materials that was sent out in an email, and then everybody here can access it too online. And then Matt had brought a hard copy, so your contact information is on that, correct, Mark? Great.
Yes, it is.
Anything else? Well, thank you so much for taking the time to join us today and share your project, and we'll be in touch, I'm sure.
Okay. Have a great meeting.
Thank you, you too. And for those online, so we'll be online tomorrow. We're breaking for the day. We'll be heading out to Jim Steakhouse for dinner. For those online though that join us tomorrow, 8:30 is when the business meeting starts. So it's a separate Zoom link. So make sure you click on the right one for tomorrow. So hopefully we see you then. Thanks so much for bearing with us while we're doing the hybrid and the dual track. So thanks, guys. And you all have directions for Jim Steakhouse, so it's not a walking distance, so we'll have to drive or carpool or however you want to get there, but it's at 6 o'clock for everybody. And the reservation will be under my name, so if you get there before I do, but hopefully not. Thank you.